Cook, Barquette, Ponder, and Wolz are very proud of the results they obtain for their clients, but you should know that past results afford no guarantee of future results, that every case is different and must be judged on its own merits, and that the choice of a lawyer is an important decision and should not be based solely on advertisements. And now, back to Tell Me I Have a Case with Dan Grimm and Matt Glenn.
All right, welcome back. I'm Dan Grimm with the law firm of Cook, Barquette, Ponder, and Wolz. And I have here with me today Andrew Below, physical therapist and owner of Advanced Training and Rehab. We're talking about common injuries we see in motor vehicle crashes. We were just talking about the low back, but we also see injuries like neck injuries that are common in motor vehicle crashes. Is that something you see as well in your practice?
We see a lot. Whiplash is the most common neck injury with a motor vehicle accident. So,
and what's causing that injury? The mechanism of injury. Why do you see in motor vehicle crashes a common injury to the neck?
Because it's like a lot of the muscles around the neck are smaller, like the sternocleidomastoid. That's the one that typically gets injured. It's a small strap-like muscle.
Say that 3 times fast.
Yeah. So it's there's like a rotational injury. A lot of times somebody might be like looking over their shoulder and then they get hit, and so it kind of torques the neck, and then you might have some disc injuries, facet injuries, muscle injuries. You can have all of it.
And same thing. So with the neck, I mean, you have ligaments that surround the neck, surround the vertebrae.
Correct.
Then you have muscles on the outside of that. Same thing. So with somebody comes sees you for neck pain, what are you looking for, and how are you treating neck pain?
Right. Like anything else with the body, not to get too boring, but we're going to do some heat and stem, try to get it calmed down, some ultrasound, some manual techniques, and then within each joint, it kind of varies after that as far as joint mobilizations, manipulations, things like that. But again, the first goal is to try to get people out of pain, try to calm down the inflammation, get things moving normally how they should. So again, we're using some soft tissue techniques. A lot of times with the neck, there's a lot of guarding of the upper trap. The body senses, all right, something just happened. I hurt a lot, so what I'm going to do is I'm really going to tense up. I'm not going to let any movement happen because movement hurts. So we need to get the body used to moving again. So we've got to do some soft tissue techniques again, massage to help loosen up the muscles. Something called a technique called like a suboccipital release. We'll put our hands underneath the head as they're laying down and provide a little bit of pressure, but then also traction, help kind of stretch out those muscles. We can also use some mechanical traction that we can provide a little more steady pressure for longer periods of time. We can do that intermittent or constant, so we can stretch it out and hold it, or depending on the patient tolerates it, in certain diagnoses we might do intermittent, where we'll stretch it for a bit and then give it a break, stretch it back out, give it a break.
Okay. So same thing, if the pain goes away, then they'll see you on an as-needed basis?
Correct. Yeah, if problems come back, but really our goal is to see the patient through their injury, again, restore movement. With the neck, we're going to work on strengthening the scapular stabilizers, provide good posture, that way the muscles are in a good spot, and then provide them the tools to take care of it on their own. They can stretch it, they can strengthen it, and then we'll just see them if they need it, if they're not able to manage symptoms on their own at home afterwards.
Okay. Another common injury that we see with clients that come in, I believe it's probably from like hold on to the steering wheel. There's injury to the shoulder, maybe a torn shoulder or a torn rotator cuff.
You got like a torn rotator cuff, maybe a torn labrum as well. That's another issue that could happen. And so our goal there as well is, again, to assess what's going on with the person. Where they're having problems, they're having problems reaching overhead, they're having clicking, popping, things like that. So we need to get things moving as they should, how they were before their injury, because prior to that, they were doing just fine. So we've got to get them back to that movement pattern that they had before.
And how do you do that?
We're going to stretch out the joint, do some joint mobilizations, stretches. A technique I like to use is some scapular moves to get the shoulder blade moving. People often think like, all right, you just got the shoulder, that's all that moves. But our shoulder blade moves as well whenever we're reaching overhead and reaching for objects. So we've got to get that moving as well. We don't have, it's called scapular dyskinesia, if it doesn't move along with the humerus when you're reaching for things.
So I see people that don't get treatment, they kind of ignore this, and I've seen what they call a frozen shoulder.
Correct.
What's that?
Yeah, frozen shoulder or adhesive capsulitis. So it happens because maybe you had a significant injury or maybe you didn't. Maybe you just kind of fell or slept on it funny, or a dog pulled on the leash when you were walking it. And you had a little bit of pain but didn't really think much about it. You kind of stopped using it because it hurt. You're like, well, I'll just avoid it. Well, then after using it to reach for things, reaching overhead for a few months, reach behind your back, it gets tight. And so instead of being able to reach into a cabinet, reach behind your back to tuck in a shirt, all of a sudden you can't do that anymore. So that's an issue we have to deal with and get things moving better. And that's when it's really good to see therapy right away for an injury as opposed to delaying it.
So you're trying to get strength back, trying to get full range of motion back?
With adhesive capsulitis, you're obviously going to start with mobility first. That's the most important thing. And then strengthen the shoulder because of that lack of movement, you're not strengthening or maintaining strength of the joint.
And when somebody gets a lack of mobility from non-use, is it a lack of range of motion where the ligaments tighten up, or also is there some type of atrophy where the muscles start I guess
losing strength? You'll have both. You'll have tightening of the capsule in the shoulder. You also have atrophy of the muscles, and sometimes you can even get, if it's prolonged, you'll have some fatty infiltration. So that's typically diagnosed by a doctor. They can do that with MRIs, figure out, good muscle tissue is going to be nice and dark. Sometimes you get some fat in there if you've had an old injury and you didn't do anything about it.
And I guess when you get a frozen shoulder, frozen socket, it's the pain's still there.
Correct. It can be very painful.
And so, I mean, again, the idea is getting treatment early helps eliminate or at a minimum reduce the pain, so you have full range of motion, full use of a healthy shoulder.
Right. Yeah. I mean, you don't want to delay that for months and not being able to lay on your shoulder or reach behind your back. Tuck in a shirt. Getting dressed, reaching overhead into a cabinet. You don't want to alter your life like that.
And also a frozen shoulder or frozen socket, is that more apt to be something that can only be fixed surgically, or is it more difficult to fix through physical therapy, or can it be fixed once it's at that stage?
Depending on the severity of it, can be either. People respond conservatively to care sometimes. Sometimes they don't. Sometimes they need to have a surgery where a surgeon will kind of go in there and kind of maybe perforate some of the tendons to loosen it up.
What I've seen from a rotator cuff surgery is a tough surgery.
Yes, it can be very difficult.
And my understanding, what I've seen, is the physical therapy rehab on a shoulder surgery is pretty long. Mm-hmm. How long? What have you seen?
It can last several months, depending on the injury. Sometimes 3 to 4, sometimes maybe 6 months. Again, depending on the severity of the injury, it all kind of depends. Everybody recovers differently too. Some people might be rock stars and recover in a few months. Some people might take longer, more like 6 months.
Is a shoulder surgery, as far as the physical therapy, one of the longer rehabs you've seen?
Yes, shoulder surgery, or maybe like a knee ACL surgery takes a while as well.
Let's talk about that. We see that quite often in vehicle crashes. A knee injury. The knee. Well, tell us. You have ACL. What else do you have?
You got ACL, MCL, LCL, PCL.
Oh my gosh! So what's the ACL? What part of the knee is that?
So it's the anterior collateral ligament. So it starts at the front of the tibia and goes to the back of the femur. Oh. And so what it does is it limits hyperextension, also helps limit rotation, which a lot of people think it's all extension. It actually helps out a lot with rotation as well.
Okay. Then the next one you said was?
MCL.
Where's that?
That's on the medial aspect, so it prevents like a valgus movement of, I guess you look at somebody walking and be like knock-kneed.
Oh, okay.
Yeah, that's not necessarily, somebody who has knock-knees doesn't have an MCL tear, but that's kind of the movement of the knee that strains that, or sprains that ligament.
And the meniscus, that's the cushion
below
the
kneecap, cartilage
right?
between it's cartilage in the joint between the tibia and the femur.
Okay, and then was there one more you said?
There's also the LCL and the PCL.
Okay, what's that?
So the LCL limits varus stress. So if you see somebody who's bow-legged, the LCL is on the outside, so it prevents that. The PCL prevents hyperflexion of the knee.
And these are all we're talking about ligaments?
Correct.
Okay, and so ligaments, again, I've heard the example like the trash bag where you can hyper stretch a ligament. It's like a trash bag. You stretch it, but it doesn't go back. Just like it doesn't go back perfectly. So it's
you can sprain it. That'd be kind of more of a grade 1 or grade 2 to where there is some tear, some stretch of the ligament. It's still, it hasn't disrupted the integrity of it, but it doesn't go back either. A lot of times you'll see that with, I know we'll talk about it later, but get to ankles. Just constant rolling, and eventually it'll just kind of go after a while.
So somebody stretches maybe a partial tear of the ACL. Mm-hmm. What's that look like for physical therapy?
So if it's let's say it's non-op. So if it's not surgical, then what we're working on is maintaining the stability of the joint. We're going to work on the quadricep, the hamstring, working on again, just stability, trying to get them, because sometimes what happens if they have a torn ACL, I've seen a few patients with this that haven't been operated on, they'll be walking, they'll feel like it wants to give way, wants to buckle on them, things like that.
Right.
So like walking through your yard to go cut your grass might be difficult, where it really wouldn't have been before, because the ACL controls that rotational component of movement.
The term, the knee feels sloppy. If you heard that before, because it's not tight. It's kind of moving around in there.
Right.
And then I guess my understanding, when you have that hyper mobility or movement, you're wearing out that cartilage at a much faster rate, which leads to ultimately what, knee replacement? You
could, yeah. Maybe it starts off with just like a little meniscectomy or meniscus repair, and once you start going down the road of like a meniscectomy disrupting the cartilage, down the road it could turn into a total knee.
So again, I mean, the sooner they get into a physical therapist, the better.
Mm-hmm.
And what do you, by getting into a physical therapist sooner than later, what are they preventing?
We would prevent that altered wear pattern like on the meniscus. We're also going to provide more stability, because whenever it is sloppy like that, unstable, it also hurts too. So we're trying to prevent that from happening as well.
Yeah, quality of life.
Yeah.
Getting you back to the way you were before this crash, before this injury.
Correct.
Full mobility, rotation, reduce pain, if not completely eliminate pain. Mm-hmm. It's a win-win all the way around.
Right.
So we also see in car crashes, when people slam on their brakes, we see injuries to people's heels, ankles, feet. What's happening? Have you seen that in your practice as far as people come in to have torn or hyper extended ankle ligaments?
Yeah, sometimes you can sprain the ankle as well. Maybe it's an inversion or an eversion sprain. So the typical injury is an inversion sprain, where you see somebody maybe lands on the outside of their foot and it hurts on the outside. An eversion sprain is a little more serious because it sprains a deltoid ligament, and that's a very strong, sturdy ligament. So once that gets sprained, that's a big deal. You could also fracture the ankle. You have like a tib-fib fracture, so maybe you have some screws and plates to hold everything together.
Wow. And with all these, whether it's a muscle tear or a ligament tear, all these, where these injuries occur, they create scar tissue, mm-hmm. right? And scar tissue is a problem.
Right.
The idea, part of getting to physical therapy is I guess, realigning the healthy tissue, which is collagen. Mm. And the more collagen and more proper it's aligned, the better chance you have of recovery and prevention of future injuries down the road. Is that true?
Right, because we want all the tissue lined up correctly how it should, so that way whenever a muscle contracts and things like that, they move how they normally would, as opposed to some restricted movement, like maybe have an old hamstring strain. You see a lot in runners who it heals enough to where they can feel pretty good. Then maybe that next time they take off, that scar tissue just kind of ruptures.
And scar tissue kind of like, when we talk about it, just kind of heals all haphazard, right?
It's a jumbled mess.
And then collagen tissue is all aligned and heals. Collagen is stretchy.
Yeah, we want all the fibers to line up.
Right. And so it can handle more force.
Right.
So think about that with an ankle injury. If you have a constant ankle pain, it's going to affect your gait. Mm-hmm. It's going to affect your mobility. I mean, it affects everything in your daily walk, right?
Yeah, it affects the whole chain. If you have an ankle issue, it could affect how your knee moves, could affect how your hip moves, and how your back moves.
So physical therapy, no matter what body part it is, it gets your body back to the way it should be fully functioning. Right?
Correct. We're trying to restore the motion that you had beforehand to create good movement patterns.
So I guess with that being said, like somebody comes back in, they have an injury. They go through a session with you or multiple sessions, and they're feeling better. They go back and they maybe have a flare-up or they re-injure it. How do they get back to you to help kind of deal with the scar tissue, the inflammation? What's the best route to get back to you to kind of get treatment they need to get back on course?
Right. They could come in and we could evaluate them. And then again, if they need treatment, they would have to go see their primary care physician, an orthopedist, chiropractor, podiatrist. Any doctor can provide a script for treatment.
Okay. And do you recommend that to where they come back in, if they have a flare-up, come back and see you again?
Yeah. I mean, we'll even help people if they're hurting. They can give me a call and say, hey, Andrew, I kind of hurt this. Is this something I can do on my own at home? I mean, hopefully we've provided them with enough of that, but sometimes they still want to know if we can help them or if it's something they just need to give it a little more time. So we'll take phone calls from them to help out.
What's a good number they can reach you?
573-319-1600.
Well, Andrew, I appreciate you being here. Again, Andrew Below, physical therapist and owner of Advanced Training and Rehab right here in Cape Girardeau, Missouri. I want to give a shout out to my partner, Matt Glenn. He's feeling a little under the weather, but he will be back next week. Until then, everybody take care.
You've been listening to Tell Me I Have a Case with Dan Grimm and Matt Glenn. If you have questions and need answers, contact Cook, Barquette, Ponder, and Wolz today. Just go to cbpw-law.com. See you next week for Tell Me I Have a Case. The choice of a lawyer is an important decision and shouldn't be based solely on advertisements.